Good morning, everyone. I'm Dr. Eric McDonald, the County of San Diego's Chief Medical Officer. Welcome to another panel discussion on COVID-19 medical and health misinformation. I'm very pleased today to be joined by two local medical experts for this discussion. They are Dr. Christian Reimers. He is the Chief of Population Health and the Director of Graduate Medical Education at the Family Health Centers of San Diego. He's board certified in internal medicine, infectious diseases, and addiction medicine, and holds faculty appointments at the UC San Diego School of Medicine and SDSU School of Global Public Health. He serves on the San Diego County's Clinical Vaccine Advisory Committee and Equity Task Forces. He's a member of the National Infectious Disease Society of America, CDC Clinical Call Escalation Volunteer Group, which responds to questions from providers throughout the country. And Dr. Reimers helped lead Family Health Center San Diego's COVID-19 monoclonal antibody infusion site clinics. He's been with us several times before, and a new panelist for this episode is Dr. Kelly Modedel. She is the Child Health Officer for the County of San Diego. Previously, she was the Chief Medical Officer and a practicing pediatrician at the Vista Community Clinic, where she worked for 17 years. She has served as a subject matter expert for our healthcare sector, as well as K through 12 schools and early childhood education during the county's COVID-19 response. In addition, she's assisted with coordinating the monoclonal antibody treatment sites at our regional treatment centers. Our focus today is the Tuesday, March 1st COVID-19 update presented to the San Diego County Board of Supervisors. And we will exclusively focus, as requested by the Board of Supervisors, on misinformation related to medical and health issues. As I've mentioned on our previous panels, the county has established a link on our COVID-19 website, coronavirus-sd.com, that is meant to help the public in evaluating information on COVID-19. If you go to our website, you will see a banner marked Evaluating COVID-19 Information. And by clicking there, you can learn more about the different types of incorrect information. There are links on the website to credible resources, some false claims that have been paired with facts, and some frequently asked questions. And this resource is updated on a frequent basis. When we're done here this morning, this session will be posted on the website. And today's session is being simultaneously translated into Spanish. And you can access that by clicking on the translate button at the bottom of the screen. With that introduction, I'd like to start with Dr. Reimers. Masks are in the news with some of the mandates going away that are being replaced by the strong recommendations to wear them indoors during periods of high transmission, and certainly to wear them if not fully immunized. I'd like to emphasize that we are currently in a period of high transmission in San Diego County. And I wonder if you could start us off by talking about how effective masks are and what you tell patients who ask you about when and what masks to wear.
Thanks, Dr. McDonald. So first of all, we've learned a lot about the type of mask, and I definitely talk to my patients as well as my medical staff really about the quality of masks. And this has been a little bit of a moving goalpost, I would say, because the virus itself has been changing and evolving, and masks that might have worked way back at the beginning, when you have a virus that's more infectious, like the Omicron variant, or especially like the BA.2 version of the Omicron variant, you kind of have to up your game. So an effective mask that, from last year or a year and a half ago might not be so effective anymore with the new, more infectious variant. So we should generally think of masks in three categories: sort of cloth masks, surgical masks, and then high quality, what I call N95, KN95, or KN90 masks. And I tell my patients really to get the best mask that they can get their hands on. That was very hard at the beginning when things were in short supply, but they shouldn't be anymore. People should really reasonably be able to upgrade to at least a surgical mask, if not a N95 or a KN95 mask that's comfortable for them and that fits their face very well. So that's really an important part, is a mask that they can wear that doesn't have big gaps either around their nose or under their chin, that really fits well. They're still very effective. So there's been a little, I think, misunderstanding that that masks really don't work anymore. I would say if you use a mask that's a cloth mask that doesn't fit very well in a crowded room with poor ventilation, it's really not going to work that well. So we need to be using better masks. I also tell people that we're going from an era of just blanket mandates to more individual responsibility and individual decision making. And that's requiring people to make risk calculations based on the situation around them. We're asking people to just sort of make decisions on their own now, instead of just being told what to do. So I generally help my staff and my patients with that, just thinking about the number of people that are there, that are outside your household, the quality of the air filtration system, or whether the air is moving at all. For example, a restaurant with one open wall versus a restaurant that's completely closed. And then the time and intensity of exposure. And we're basically just going to have to make those individual calculations. The one example I like to bring up is an airport. There are thousands of people in an airport. That is one place, even more so than an airplane, where the highest quality mask is really, really necessary. So I'll stop there.
That's really great. I think the important things are to know that we are still in a high transmission time frame. In fact, with our wastewater surveillance, we know that the burden of virus in the community is actually as high now as it was during the entire Delta surge. So even though things are better, I think that's an important comparison to know that there's a lot of virus circulating in the community. And Dr. Modedel, any comments you wanted to make about masks and kids?
Well, as we know, the masks are going to no longer be mandated in the schools in a couple of weeks. And I, just want to piggyback on what Dr. Raymer said about then needing to sort of take other additional measures to protect yourself. And we know that our vaccination rates in our children in this county are lower than we'd like them to be. And that is definitely an additional layer of protection that we could be providing our kids as the masks will be fading away. Of course, it's certainly still appropriate and acceptable if people want to wear their masks at school. We want to encourage that to continue to happen. I think there's definitely also concern amongst children that kids who are masking when it's not required may be on the receiving end of negative comments. And so we really want to educate our kids all the way around that this is now going to be a personal choice, and people have to, as Dr. Raymer said, take personal responsibility and allow people to do that to protect themselves.
Indeed, protecting children means protecting their families. And I do want to emphasize that issue that as we move to a place where there is choice in schools, it is very important that families who want their kids to be able to comfortably wear masks in schools are able to do so, because they're making that choice and doing a calculation for risk, as Dr. Raymer's mentioned, that often involves, frankly, protecting their family. And I do want to be sure that we are cognizant of that as we move forward into a time where there's less circulation in the community. Dr. Ramers, one of the public comments on Tuesday referred to some statements made by Dr. Peter McCullough, a cardiologist who's advocated certain early treatments for COVID. And on some of our previous panels, we've addressed the issue of repurposed medications to treat COVID, and of course, the other treatments that are evidence-based that have shown to be effective in preventing bad outcomes from a COVID infection. I wonder if you can tell us what's new, if there's anything new regarding the outpatient treatment for COVID.
Yeah, thanks for the question. We now have really quite a good series of tools that we can use for people with early COVID. And this has become gradually organized into the NIH guidelines, which really have several options that we can use for people with early COVID. I'll go through each of them very briefly. The first is Paxlovid, and that's at the top of the list. That's an oral medication that you take for 5 days, must be given within 5 days of symptom onset. So all of these will demand that people need to test really right away as soon as they have symptoms, and then reach out and try to find availability, which is actually getting better and better. So Paxlovid really should be accessible to people around the county. At Family Health Centers, we're dispensing it. A lot of CVS and other pharmacy stores are dispensing it as well. So really available. And this is a quick, easy 5-day course that reduces the chances of severe disease by about 90%, really fantastic efficacy. The next is monoclonal antibodies, and these were some of our first therapies known to be effective, also in the 80 to 90% range at decreasing hospitalization. We want to get these also relatively early. The earlier, the better. Monoclonals can be given up to about 7 to 10 days after symptom onset, but of course, the earlier, the better. And there are several sites throughout the county, including at family health centers, where these can still be given. And then we also have additional therapies if those are not available. Molnupiravir is another oral medication. All of these now have a nice, solid evidence base showing us that they are effective at preventing hospitalization. And a lot of the early repurposed medications like hydroxychloroquine, azithromycin, ivermectin, other things like that, as the evidence has built up, it's looked, well, it never really looked great, but it's been more and more, we've been more and more certain that these other things do not work. In fact, there was a recent randomized controlled trial, another one that came up about ivermectin, and it just did not show any efficacy at all compared to the standard of care without ivermectin. So it never has been endorsed. I know there's some fanatics, including Dr. McCullough and others, that really want to believe that it works because it did in the test tube when you use extremely high concentrations of it. But when we get things out into the clinical arena, the evidence just is not there for effectiveness. And yet we have a lot of other options, which are now becoming even more available on the global scale as well.
Yeah, I think it's important to emphasize that early on, when there was not a lot of choice, there was a lot of advocacy for some things that may have been thought to be useful, but it's important that we do the studies to actually look at people who got the early treatments and those who didn't, to see if there was truly effect and indeed no harm to those individuals. Maybe I can have both you and Dr. Modedel answer this question. You've both been involved with monoclonal antibody treatments for San Diegans with COVID. Do you have advice for them about how they should seek treatment and who should be seeking treatment with monoclonal antibodies?
I can talk to the logistics and in particular. So we do have a regional number that allows folks, regardless of immigration status or health insurance status, to access the monoclonal antibodies, which is 619-685-2500. And so that would be an option for those who do not have another place to go. That will take you to Dr. Raymer's facility or any of our regional centers that we have now in San Ysidro, in Claremont, and in Vista. In addition, many of the healthcare organizations throughout our county have that available now. They did not have as much capacity to give it earlier because there was so much activity in their emergency rooms and in their hospitals. But now, as those things settle down, they will probably have more access directly. So it's always a good idea to check with your primary care doctor, if you have one first, about accessing it through their facilities as well.
And to your second part of your question, who should seek treatment? When there were more than 10,000 cases a day in the county, we had to really triage and prioritize those with the highest risk. We're in a little bit of a different situation now. I would say most people who want treatment should be able to seek it out. We're going to, of course, still prioritize those with higher risk because of age or underlying comorbidity or vaccination status or immunocompromise. But now that we have really good ability to provide these therapies with a risk-benefit discussion with the patient, most people should be able to access treatment. And that includes both the oral antivirals as well as the monoclonal antibodies.
You mentioned immunocompromised people, and I think it's worth emphasizing that people may not be aware of how many fellow San Diegans actually are immune compromised, and why it's important we all are aware of the things that we can do that affect that specific population. And I wonder if you could talk to that just for a moment, Dr. Reimers.
Yeah, this is a large and heterogeneous group of people. So some people are immunocompromised because they got an organ transplant. Some people have HIV/AIDS. Some people take medicines to treat other medical conditions, whether they be skin conditions or GI conditions or arthritis or rheumatologic conditions or lupus or things like that. Many people have some degree of immunocompromise, and unfortunately, they don't get the full benefit of vaccines because of their immune systems. I have to say there's kind of an outcry in this community that the burden of COVID is being shifted to them because they are still quite vulnerable and they are still definitely going to be wearing their masks. But I do want to say that there are things we can do for these people. The numbers you asked about, there was a study in the Journal of the American Medical Association a couple of years ago, estimating that it's about 3% of people out there that are immunocompromised to some degree. You apply that to about 3.3 million people in San Diego, and it turns out to be about 100,000 people. So, you know, I can't make everybody care about protecting their neighbors and protecting the vulnerable people in their society, but I certainly do. And that's a reason to wear a mask, actually, to protect those people who may not have good immune protection. We do have things that we can offer people who are immunocompromised in addition to alternate vaccine schedules. We actually think we can get a little bit more out of the vaccines by giving additional doses on a different schedule for immunocompromised people. And there actually is one monoclonal antibody that can be used as prevention. And this is something called Evusheld. And we can give it to immunocompromised people to give them what we call passive immunity. We've been giving this at Family Health Centers as well as other sites. And that is an additional thing. But I think, you know, somebody famous once said that, you know, we should be judged by how we protect our most vulnerable members of society. And I really believe that's true. And the immunocompromised in this very moment are really feeling the brunt of COVID still.
You know, I think that's a really great point. And I have to say that I'm really proud of the majority of San Diegans who, in fact, really do care for their fellow San Diegans and have done over the last 2 years a lot, just personally and through their actions to protect their fellow San Diegans. We've had lower rates here in this county compared to actually other Southern California counties for COVID. We've done a better job of protecting the most vulnerable. We need to keep that in mind, even as the numbers come down. COVID is still out there and is still potentially dangerous to these individuals. So thanks for emphasizing that point. Another issue that came up in a couple of comments in the Tuesday meeting regarding kids. There were comments that kids don't get COVID and that kids don't transmit COVID. And I wonder if Dr. Kelly Monadel, if you could just talk to that a little bit, you know, talk about the experience we've had here in San Diego, actually about the effect of COVID here.
Yeah, absolutely. You know, I think that was a missed opportunity in our messaging early and throughout the pandemic that this was not affecting children. And I think that came from the fact that we often compared rates of infection and death in children to our elderly and our adult population, which we don't really do with any other disease. And so I think that was, you know, a disservice to our kids because really, even one child dying from a preventable disease is tragic and has a ripple effect throughout the community. So for that reason alone, we really want to continue to protect our children. And in addition to the immunocompromised, we still have a whole age group of 0 to 4 who's not immunized and does not have that extra immunity as well. So with that, we have seen cases in kids. And I think Omicron really changed the story or should have changed the story even more. We saw our rates in children skyrocket here in San Diego during that time to the point where now, if you look at numbers overall in our county throughout the pandemic, the percentage or the rate per 100,000 0 to 9-year-olds actually is as high, if not higher, than the rate of our 60-year-olds and our 70-year-olds or our 80-year-olds. So really a lot of kids were impacted with the Omicron, and we're now starting to see, here we are a few weeks out from that surge, we're starting to see that late complication of the multi-system inflammatory syndrome. It's starting to appear. I'm hearing from our children's hospitalists, they're starting to see more cases of that in our hospital. And we don't know the long-term effects. We know that we're starting to see other things possibly impacting kids as well as the long COVID like it does adults. Perhaps there's an increased risk of diabetes. So it's more than just about how sick they get during that infection. But the other thing we found with Omicron is that it does spread from kids. There was actually a study that just came out last week looking at households, and about 50% of people who lived in a household with someone with Omicron ended up infected as well. But where that was seen the most was when a 0 to 4-year-old was the first one sick. And so these kids are spreading it. This is not the same coronavirus we saw earlier in the pandemic. And unfortunately, we need to try and change the messaging on that.
Another comment that was made is that there aren't outbreaks of COVID in schools, and that just simply isn't true. Last week, we had 57 community outbreaks, and 28 of them were in the school environment. So I think that, again, people just need to be aware that kids do get COVID, and there are unfortunately sometimes some bad sequela from that. But how are we doing with immunizing kids here in San Diego? And where are there areas where we might be able to do better?
Yeah, so we're doing a little better than the rest of the nation, but unfortunately that's still very low. So we're at now just under 32% of our 5 to 11-year-olds who are fully vaccinated, and just over 40% of those who have received just one vaccine. And our rates across the county are much higher than that when we look at our total population. But even if we look at how that compares, the vaccine's been available for about 4 months for this age group. If we compare that with the vaccine rates we saw in 12 to 16-year-olds, 12 to 15-year-olds, when that became available last May, 4 months out, we were in the 60% for those that were fully vaccinated. So I know there's a lot of families who they themselves are vaccinated but are hesitating a little bit more with their children. And so even though we are seeing that number climb, it is climbing very slowly, and we definitely need to do better. And as masks come off at the schools, as I mentioned before, this is a great opportunity for people to really think how they're protecting their kids and their community by getting their kids vaccinated.
Any extra comments, Dr. Reimers, or maybe I can move on to the next topic?
Yeah, I think that there's some news reports about vaccines in the 5 to 11-year-olds, maybe not being as effective as we'd like. I think what's happening here is that we are still learning. We're always learning about how these vaccines work. 2 doses of vaccine in the 5 to 11-year-olds may ultimately not be enough. Most childhood vaccines, if we talk about polio or meningitis or Haemophilus influenza or tetanus and pertussis, are 3 to 4 dose vaccines as well. So that may be something that we learn a little bit more in the future. But when you look at some of this recent data that has actually come out about drop in effectiveness of vaccines in the Omicron surge, what still does hold up quite well is the protection from severe disease. And we have many other examples of very good vaccines that don't necessarily protect 100% from an infection, but will protect against the worst outcomes. And really, that's the whole point of vaccinating our children.
While we're talking about protection, there were a couple of comments made at yesterday's or at Tuesday's meeting. One, that it was that you were more likely to die from a vaccine than you were from actual respiratory disease, and that case rates were actually higher in people who were vaccinated versus those who were not vaccinated. Now that's in direct contradistinction to what Dr. Wooten actually presented in her slide set. But I'll say, based on our local numbers, I think it's important to know that the cases are 3 times higher in those who are unvaccinated compared to those who are fully vaccinated and boosted. The hospitalization rate is 5 times higher in the unvaccinated, and the death rate is 7 times higher. And even when talking about those rates, which I think directly refutes those types of comments that were made at the Board of Supervisors meeting, the actual people, the populations are slightly different, so that the average age of people who are getting infected in San Diego here in the last month or so who are unvaccinated is 28, whereas those who were fully vaccinated and boosted were actually twice that age, 47 years old, or nearly twice that age. The average age of somebody being admitted to the hospital who's not vaccinated is 59 compared to 72 for those who are fully vaccinated. And the deaths, they tend to be a decade older in those who are vaccinated versus those who are unvaccinated. And so the populations are different, and there's been confusion with statistics that are thrown around. We've actually mentioned that before. Someone misquoted our director of the CDC as saying that the majority of individuals, or 75% of individuals who died with COVID, had 4 or more comorbidities. That was actually true only of people who were fully vaccinated. It was not true of those who were unvaccinated, who did have, on average, at least one comorbidity, but the most common was hypertension. The next most common was obesity. So I think it's important to look at those rates and know that our real experience here in San Diego is that being fully vaccinated and boosted is protective. And that's been shown really across the country with independent local health agencies, state health agencies, and of course our own CDC and international health agencies.
I'll just jump in, Dr. McDonald. I think we've seen this a lot, where you can take a pretty basic epidemiologic calculation and just get it wrong or twist it, and it results in a different message. But we have many professionals that have spent their careers long before COVID giving us epidemiologic figures and calculating rates and all this kind of thing. And it's just a little disappointing that some people are twisting what the numbers actually are to try to make them look different. It's the denominator that's how we calculate rates. And as we reach 80 to 90% of our population that's vaccinated, the pool of people that could potentially get what used to be called a breakthrough infection is so much larger that's why we use rates. It's like epidemiology 101 that everybody should know. So a little disappointing that people use that. And then I also want to make the point that some people like to point at these breakthrough infections and say, look, the vaccine doesn't work at all. The people that are having the worst outcomes are the absolutely most vulnerable with advanced age and immunocompromise. And so for many people, it can take a severe disease and make it a mild to moderate disease. And in the most vulnerable of our society, that mild to moderate disease can still have a severe outcome. That's why we really emphasize layered approaches. And this is just really, basic medicine, epidemiology, and public health that we all understand. And it's disappointing to see people try to twist things around.
It's disappointing. And, one of the other things is that one of the commenters at yesterday's board meeting drew attention to something I know that is important to you as an addiction medicine doctor, is the opioid overdose crisis, and talked about how with our skyrocketing numbers in San Diego and really across the country, this is an important public health crisis, and therefore we shouldn't be worried about COVID-19. Actually, that's the complete opposite. We should be worried about both. And the fact that these two pandemics or epidemics have really interacted with each other is an important consideration as we look to figure out how to address the opioid overdose crisis. And I can tell you that we at the county level have recognized this from really before COVID-19 began, issuing health alerts, talking about the increasing numbers of deaths and overdoses from fentanyl, and that has increased. And so I think that there's a tendency for people to think that we should be thinking either or in terms of our actions to protect the public health. We need to work on both, and I wanted to emphasize that and see if you had any comments there.
Yeah, I'll start. We don't get to choose the diseases that our patients have. We kind of have to take care of all of them. And I will agree, I'm an addiction medicine specialist, and I do everything I can to address opioid use disorder. And it's been absolutely tragic, the deaths that have occurred, over 100,000 deaths, mainly due to fentanyl overdose, people injecting drugs alone without the availability of Narcan or naloxone to reverse those overdoses, as well as the mental health impacts of the pandemic. That's part of it for sure. I'm not going to deny that. But we absolutely need to be able to walk and chew gum at the same time and address multiple public health threats at the same time, which is exactly what we're doing. That's what the county public health infrastructure has done with harm reduction services that are now, I'll add, much more widely available than they ever were, because the ban on harm reduction has been lifted throughout the county. There are dedicated teams out there on the streets, really multiple nights a week, handing out Narcan and trying to get people into drug treatment programs of buprenorphine and other things. So Of course, we've been doing this. This is what you do when you go into medicine and public health. Perhaps maybe we can spend a little more attention towards the opioid crisis now that COVID numbers are receding a little bit, but both problems are clearly prevalent in the community right now.
Yes, I think that they both will be with us for a while, and it's important that we keep the focus on this. There were some other just individual claims made that have been made before that just are clearly out in left field, I hate to say. I mean, there was the claim that the COVID vaccine causes HIV, and that there are microchips in the vaccine, and that the vaccine is somehow a gene therapy. Those are all demonstrably false, and I do want to just say that because I think it needs to be, just clearly stated that those comments that were made as if they were fact simply are not true. And I think that covers most of the specific issues that were raised, but I did want to just give both you and Dr. Bodedel a chance to say, in your interactions with the public and with your patients, are there misinformation issues that you think are worth mentioning that we need to direct folks to competent resources in order to counteract?
I can start, and I'll just continue the conversation you were mentioning about some of the myths around the safety of the vaccines. And we just continue to see more studies come out showing the safety as well as efficacy of the vaccines in teens, in kids. The efficacy against severe disease and hospitalization, as Dr. Reimers mentioned, but safety as well. I know there was concerns about myocarditis in our teens and young adults. And what we're seeing is the booster dose is having less incidence of that. But even in light of that, there's such rare events that we know the benefits outweigh that risk, and that we continue to encourage and recommend that is the safest way to help prevent COVID. So I think those conversations, if people are still having questions about that, those conversations can be had with your doctor, and reach out to our website, as you mentioned before, Dr. McDonald, that has some great resources as well. And in particular for the pediatric population, the American Academy of Pediatrics has some wonderful resources on their healthychildrens.org website that is specifically targeting an audience of parents. It has videos in English and Spanish answering some of those most common questions and addressing those concerns.
And I'll just add that, I think we are in a confusing time because there are people that want to just pretend that COVID never was a thing and that it's over. And neither of those are true. I'm struck at how tolerant we have become of very high numbers of transmission. And, the county has reported, I think yesterday, 952 cases, which if we go back a year, that's still a very high number of cases. Our positivity rate is 5.2%. Anything above 5, we generally consider relatively high. And we've crossed over 5,000 COVID-related deaths in the county, approaching 1 million in the country. And in San Diego, 44 deaths in the last week. This is the leftover of the large Omicron surge. So going forward, it is confusing about where we are and what we do, but to pretend that it's over is really not the right action. I think to smartly move forward and carry with us the things that we know work is the way to do it. And most infectious diseases kind of take a break during the summer and then come back in the fall and winter. So I think we really need to be prepared for what's coming ahead. There are parts of the world that still have very, very large outbreaks. In South Korea and Hong Kong and New Zealand, they're actually seeing this than they've ever seen, Australia as well. So all it takes is evolution to occur in one of those places for a new variant to give us more trouble. So we just need to be vigilant and prepared, and at the same time move forward and try to get back to more of our normal activities. If you've been putting off a trip or wanting to get out more, please do it, because we need to take care of our own mental health. But we also need to be vigilant and not discard everything that we've been able to learn. The context is very different. It's really the vaccines and the early treatments that have given us a major cushion to be able to move forward and do a lot more of the activities that we love to do.
I think that's a really great place to end, Dr. Reimers, because I really do think that we do need to take stock of these last just over 2 years of dealing with this pandemic and understand how we can take the lessons we've painfully learned and just bring that forward into what we do in the future. And I'm actually very confident that everyone in San Diego can do that, to tell you the truth. So I'd like to thank you, Dr. Reimers, and you, Dr. Ronadel, for your participation today. And I'd also like to thank our county communications team who did the work to set this panel up. Also, our two translators, Tanya Flores and Lucrecia Rodriguez. And I hope that you will go to our website, coronavirus-sd.com, to learn more. And that will conclude our session today. Thank you for attending.